Testing ujian suara 1 2 3 1 2 3 1 2 3. Testing ujian suara 1 2 3 1 2 3.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Yang berbahagia datuk-datuk, datin-datin di Putan dan tuan-tuan yang dirahmati Allah sekalian. Kita akan memulakan sesi CME kita sebentar saja lagi. Di sini terdapat beberapa pengumuman. Bagi mengisi kehadiran CME, tuan-tuan diminta untuk scan QR code yang dipaparkan di layar ataupun peserta yang menggunakan YouTube channel boleh menggunakan link kehadiran di dalam live chat YouTube channel. Dan jika berkesempatan, kita akan adakan sesi soal jawab kepada peserta yang join melalui YouTube channel, boleh bertanyakan soalan melalui live chat di YouTube channel kita. Dan selepas selesai sesi CME, majlis kita akan diteruskan dengan sambutan Hari Asma Sedunia, peringkat Hospital Raja Purwakarta 2 dan pelancaran klinik asma teruk. Jadi diminta kepada semua peserta sambutan Hari Asma Sedunia untuk terus kekal di dalam auditorium. Saya saja. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Assalamualaikum warahmatullahi wabarakatuh. Yang berbahagia Datuk Dr. Zaini bin Hussein, Pengarah Kesihatan Negeri Kelantan, Deputi Jabatan Ketua Jabatan dan hadirin hadirat yang dirahmati Allah sekalian. Alhamdulillah pada pagi 7 Syawal yang indah ini kita masih diberikan peluang untuk sama-sama mengikuti sesi pembelajaran berterusan CME pada kali ini. Saya Nik Muhammad Fikri bin Muhammad daripada Jabatan Farmasi Hospital Raja Purwakarta 2 akan mengacarakan majlis pada hari ini. Hadirin hadirat yang dirahmati Allah sekalian, bersempena dengan sambutan Hari Asma Sedunia peringkat Hospital Raja Purwakarta 2, sesi CME pada hari ini akan mengupas topik yang bertajuk Closing Gaps in Asthma Care. Tanpa melengahkan masa, ini saya serahkan pentas kepada Dr. Suzila binti Cik Sayuti, pakar perubatan respiratory dan Dr. Tiof Siki, Fakta perbuatan dan penuh respiratory untuk meneruskan acara. Silakan.
Terima kasih kepada pengurusi majlis. Assalamualaikum warahmatullahi wabarakatuh and good morning everybody. Mainly on behalf of Respiratory Medical Department, I would like to thank everybody for joining us in celebrating our World Asthma Day for our hospital level this year. And mainly, I and also my colleague will start our program today with CME session. I'm going to present our CME on topic of closing gap in asthma care. So some introduction about World Asthma Day. Why we celebrate World Asthma Day? Mainly because of this is help to raise awareness of asthma worldwide. And then actually this program was first held in 1993, organized by Global Initiative for Asthma, or short form known as GINA, and has grown each year to become one of the most important asthma event globally, and it being celebrated on the first Tuesday of May. Globally, this World Asthma Day was celebrated on 3rd May. But 3rd May, we still celebrating our Hari Raya, so that's why we move our celebration to today. Okay? So as we know, asthma cannot be cured, but it is possible to manage asthma to reduce and prevent asthma attack or exacerbations. And then mainly there are numbers of gaps in asthma care which require intervention and to reduce preventable suffering as well as the cost incurred by treating uncontrolled asthma. So that's why because of many gaps in asthma care, that's why Gina come up with a theme for this year for World Asthma Day as closing gap in asthma care as the theme for World Asthma Day 2022. So that's the reason why we choose this topic as our topic for our presentation today. So when we talk about asthma care, what are the gaps mainly? There are numbers of gaps in asthma care include actually even though we have guidelines, we still having limited knowledge. Some of our healthcare providers have limited knowledge about asthma. Right? So we try to prevent this. We try to reduce gap regarding knowledge, especially among our healthcare workers. And then we also having problem with unequal access to diagnosis and treatment for asthma. And then we have gap in communication and care across the primary, secondary, and also tertiary care. And then we have lack of communication and education provided for our asthmatic patient. And then next issue, we have gaps between prescribing inhaler, monitoring compliance to medication and ability to use them. And then last one, we have discrepancy in terms of scientific evidence and then actual delivery of care for our asthmatic patients. This still happen in our daily practice. So that's why this year, this is our challenge for this year. We need to work together to identify and close the gap in asthma care, and then we need to implement some solution or innovative locally to improve our asthma care for our patients. First gap, as I mentioned earlier on, this is main issue, especially among healthcare providers, gaps in asthma knowledge. And then for us, for knowledge, this is our reference. We have our own CPG, but our CPG, Malaysian CPG, published in 2017. This is about 5 years ago. And then some information in this CPG we can still use as our reference. But mainly globally, we use GINA, which Global Initiative for Asthma recommendation as our guideline in terms of treating or manage asthma based on latest evidence and based on latest recommendation by latest study. Okay. This is some introduction about asthma. Actually, asthma is an inflammatory disease. Mainly, patient presented with respiratory symptoms such as wheezing, shortness of breath, chest tightness, cough, and then mainly the symptom varies over time and intensity. And then why this patient have this symptom? Because of presence of airway limitations. This picture mainly shows that patient having this is the abnormality of airway. Those who having asthmatic attack, mainly the airway of patient become narrowed because of ongoing inflammation. The smooth muscle cell the smooth muscle of the airway become tightened, thickened, and then cause air trapping in the alveolus. So this rise to all the respiratory symptoms in asthmatic patient during exacerbations. So mainly we tend to diagnose asthma based on history. Mainly patient presented with typical history as I mentioned earlier on. And then mainly they experience more than one of these symptoms. And then symptoms mainly worsen at night or early morning. And then it varies over time and intensity. Then sometimes their symptoms mainly worsen with URTI symptoms, exercise exposure to allergens, and then exposure to irritants such as fume and smoke. Right? And then we did ask also regarding history of atopy and also family history of asthma in our asthmatic patient. How actually we come up with diagnosis of asthma? This is investigation that indicated in asthmatic patient. We need to do spirometry to establish diagnosis. Mainly, we can see that patient having obstructive ventilatory defect with significant reversibility post bronchodilator. We can see that patient having increment of FEV1 post bronchodilator about 5% and 200 mils. This is typical for asthmatic patients. Right? Besides that, we can monitor the peak flow meter and also we can proceed with the bronchial provocation test. And then for specific for allergy asthma, this is quite interesting because we have lots of patients with allergy asthma in our unit. So we have specific investigation such as serum IgE, FeNO, this is short form for fractional exhaled nitrous oxide, and also blood eosinophil. You need to monitor this in allergy asthma. And then later I will elaborate why we need to monitor this. Okay, how about in Kota Baru? Hospital Kota Baru, we actually fully equipped with all the investigation to certain our diagnosis of asthma. We have spirometry, we have spirometer machine, we call as spirometer, and then we have the bronchial provocation test machine, but we're waiting for metacolin. So hopefully we will start this test by next year. And then we have FeNO. Again, this is mainly benefit for asthmatic allergy asthma to establish diagnosis of patient having eosinophilic hyperinflammation in the airway. It guides us in terms of diagnosis and also treatment option for our patient. Another one, we have IOS. This is short form for impulse oscillometry testing. This is mainly very important for severe asthma patient. Those who complicated with small airway disease, and then mainly they are, if proven they have small airway disease, meaning that they are indicated for extra fine particle inhaler. So this is how we choose our investigation, how we select our patient, which investigation benefit for them. So regarding gaps in access to diagnosis, I think this is an issue in district hospital and also clinic kesihatan, our primary care. Because mainly we tend to diagnose asthma based on history and clinical finding. Once patient presented to you with history of nebulization before, with strong family history of asthma, with bronchospasm, you straight away diagnose patient as asthma without further investigate. Some of our patients don't have basic investigation, such as PEFR, spirometry, and even no chest X-ray to exclude other differential diagnoses. This has happened, isn't it? So for your information, as I mentioned earlier on, spirometry actually recommended test to confirm diagnosis of asthma. And then for your information also, we have spirometer in most of our district hospital. And then we have trained staff. Actually, this is our staff in Hospital Tengku Anis, our staff nurse. And then this is our ME in Hospital Sultan Ismail Petra doing the test. So they all trained for spirometry testing. And then they are qualified for that. So those who in district level, KK, if you don't have these facilities, you can refer to nearest district hospital for spirometry. Hopefully in future, all our asthmatic patients have baseline spirometry tests. And then this is again for allergy asthma. We have this, we call this as biomarkers. the test that available in our unit mainly FINO. This is something new for us. We start to have this machine mainly since last year. This is how the machine look like. And then this is a very simple test. The machine will connected to computerized system, and then we connect the device to the mouthpiece and ask patient to exhale for a few seconds, and then mainly this test will measure the nitrous oxide that expressed by inflammatory cells in asthmatic airway of our patient. So this is indicated mainly for those who have allergic asthma to prove that they have eosinophilic inflammation going on, and then they are mainly candidate for inhaled corticosteroid. And then this test beside then confirm the diagnosis of allergic asthma, we can use as monitoring tools to assess patient response towards our treatment after we initiate inhaled corticosteroid. Then this is the examples of result FINO test in our hospital. Beside that, we can send serum IgE, but this one we send to IMR, and then please you must document your patient blood eosinophil count, absolute count, because this is very important later on, especially among severe asthma patient. And then of course for allergic asthma patient, we need to proceed with skin prick test. We need to look hard what are the triggers. This is offered by our colleague ENT and also the dermato department. And then if patient high risk for anaphylactic shock with bad skin eczema, so another test that we can offer for our patient mainly RAS test. This is short form for radio allergosorbent test. This is blood taking, specifically test for serum immunoglobulin E for specific allergen. This is examples of RAS test result from IMR. Okay, and then another issue with our treatment, really we have gaps in access to treatment. I think Kota Baru our respiratory unit, no issue about this. But this is happened in primary care. Actually, we have discrepancy in terms of scientific evidence and actual delivery of care for our patients. And then we need to remember that when we treat patients with asthma, this is mainly our goals. As I mentioned earlier on, asthma cannot be cured, but it is possible to manage asthma to control symptoms and prevent future exacerbations. And our target, and mainly when we start treatment, patients have less symptom, no sleep disturbance, no limitation in daily activity. And then we can maintain patient lung function, prevent exacerbation, prevent asthma death, and also avoid medication side effect, especially for those who have uncontrolled asthma and then need frequent systemic steroid, either oral or IV hydrocortisone. So before this, when we talk about asthma treatment, everybody will think of nebulization, isn't it? And then MDI, sure, salbutamol, Ventolin, Astalin. This is the main treatment for our asthma patient. SABA, short-acting beta-2 agonist, mainly equal to Astalin, Ventolin, salbutamol, has been used as first-line treatment for asthma patient for more than 15 years. 50 years, okay? And then, since 2019, GINA come up with consensus. This is based on latest evidence, based on studies, treatment of asthma with short-acting bronchodilator alone, no longer recommended for asthmatic patients. Yeah? So, reason behind why SABA, we can't use SABA alone, because as we know just now, SABA does not control underlying inflammation asthma. Asthma actually chronic inflammatory disease. So we need to tackle inflammatory part in our asthmatic patient, especially during exacerbations. So based on study, regular use of SABA, even 1 to 2 weeks, it is associated with significant adverse effect. Mainly patients have beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, decreased bronchodilator response. Even though they use it regularly, but mainly patient symptom not much improved. This happen if you use prolonged use of kata sabar alone during exacerbations. And then it also increase allergic response, increase eosinophilic airway inflammations. So higher use of sabar is associated with adverse clinical outcome. Dispensing more than 3 canister per year associated with high risk of severe exacerbation. 1 canister consists of 200 puffs of medications. And then if we dispense of 12 canister per year, it is associated with much higher risk of death. That's the reason why GINA, mainly since 2019, not recommended sabar alone as reliever in acute exacerbation of bronchial asthma. So this is GINA 2021. They come up with consensus in terms of how we approach our asthmatic patient. Mainly this is based on step-wise approach from step 1 to step 5. And then they divide into track 1 and also track 2. Preferred reliever mainly must consist of low-dose ICS formoterol. And then in our market, we have in our hospital, ICS formoterol, we have combination formoterol plus budesonide and also formoterol plus beclomethasone, Foster and Symbicort. If you don't have this, you can use track 2. Track 2 meaning that if your patient have mild asthma, whenever they have exacerbation, they must take ICS whenever sabar taken, because we need the effect of steroid to suppress the inflammation going on in acute exacerbations. We can still use sabar as reliever, but we must make sure that our patient already on maintenance, inhaled corticosteroid, and patient comply to the medications. Okay. So this happened. This is mainly, I think this is at the primary care, district level, klinik kesihatan, or district hospital. Our patients still symptomatic, but because of limited treatment option, we just continue the same treatment. Isn't it? This happen, isn't it? Even in our setting, sometimes this happen. So don't just simply continue the medication. If your patient is still symptomatic, please refer to us. Please refer to our respiratory clinic. Mainly, this is some roughly indication for referral. If your patient not met the goal of asthma therapy after 3 to 6 months treatment, meaning that your patient is still symptomatic, please refer early to us. So, meaning that you declare that your patient unresponsive to your treatment. And then if your patient have atypical symptoms, and then you think this could be something else rather than asthma, so you can refer to us to confirm, to establish diagnosis of your patient. Or complicated asthma, those who complicated with chronic rhinosinusitis, GERD, with OSA or asthma COPD overlaps. So those who require step 4, meaning that patient require high dose inhaled corticosteroid, still uncontrolled symptom, this patient maybe you can refer to our clinic for further evaluation and assessment. Maybe your patient complicated with small airway disease, and then actually they are candidate for IOS as I mentioned earlier on. And then if your patient have frequent exacerbation and then need oral corticosteroid or high dose inhaled corticosteroid and has required more than 2 bursts of oral corticosteroid in 1 year, this is another indicator for referral. I think some of our patients reluctant to come to Kota Baru because of logistic issue, because of distance, because of limited parking, kan? Betul. So that's why mainly we expand our service. This is since past few years, but during pandemic COVID, we hold temporarily our service. This year we start again. Since January, we start again visit our few district hospitals. We went to Hospital Tukar Anis every month, and then we target about 20 patients to be reviewed in our outpatient clinic and also inpatient. Hospital Kuala Krai, we visit every 2 weeks. Mainly, we also did procedure there, bronchoscopy and fluoroscopy. We did visit Tumpat every 2 weeks, and then Hospital Pasir Mas every month. So, For those who in district, please make use of our visiting clinic to refer your case, especially uncontrolled asthma, for further evaluation. At least we can roughly assess patient how to go about. Either this patient need special test or special attention, and maybe a certain case we can select for proper assessment in our hospital setting in our respiratory clinic Kota Baru. And then next issue actually gaps between prescribing inhalers and monitoring adherence and ability to use the device. I think everybody aware that when we talk about device, we have many devices, isn't it? We have the MDI, AccuHaler, HandyHaler, Respimat, Addicta, TubuHaler. Actually, all the devices have different technique, and then patient must have different inspiratory flow rate to make sure that all the medication delivered to targeted area. And then based on study, they noted that contributing factor for exacerbation mainly due to incorrect inhaler technique and also suboptimal adherence to inhaler. So this is study done. This is one of the study done by our colleague FMS colleague, and then they published in their journal. Mainly about 72% of their study population mainly have improper MDI technique. So you can imagine, isn't it? MDI actually, this is quite common device that we prescribe for our patients. So because of that, to prevent gaps in between compliance and then incorrect technique, so we have this service in our clinic, what we call as MTech service. This is called the medication therapy adherence clinic. This is run by our dedicated pharmacist, Madam Eileen. She's our respiratory pharmacist. And then each visit, mainly she will assess our patient in terms of compliance, keep giving the medication counseling, and then reassess the inhaler techniques, especially those who are still having uncontrolled symptoms. So, so special for Kota Baru, we need to assess asthma severity. Mainly mild asthma, moderate asthma can be managed by klinik kesihatan because we have the FMS, and then certain drugs mainly available in klinik kesihatan. So in Kota Baru, mainly we concentrate on severe asthma. Most of our patient asthma can achieve good control of their disease with appropriate treatment and compliance. I think this is quite common presentation to our ward. Mainly when we look at again why this patient having exacerbation, mainly they still exposed with other triggers, and then mainly the non-compliant to the medication. But we have a significant proportion of patients with asthma remain symptomatic despite treatment of high-dose corticosteroid, LABA, or LAMA add-on their treatment regime. So some of our patients still required systemic corticosteroid, oral steroid. So meaning that some of our patients did comply to medication, already on triple therapy, but still uncontrolled symptoms. This is mainly candidate for referral to our severe respiratory, severe asthma clinic. Right? And then that's why we need to identify asthma severity. Either our patient under uncontrolled asthma, difficult to treat asthma, or severe asthma. Why? Because now we have more option of treatment available for severe asthma. So this is in our respiratory clinic Kota Baru. Mainly, we dealing with step 4 and then step 5 patient. Mainly patient already on high-dose corticosteroid, triple therapy, and then some of them already on targeted therapy. So we need to identify, we need to differentiate between these three groups. Uncontrolled asthma, mainly patient remain symptomatic and then have frequent exacerbation. Meaning that this is, many of these patients may potentially have mild asthma, but the medication is suboptimal. If we start proper treatment, appropriate treatment for our patient, their symptom we can control the symptoms. Difficult to treat asthma doesn't mean this is difficult patients, but defined as asthma uncontrolled despite prescribing high-dose preventive treatment. But still, yet patient have other contributory factors such as incorrect inhaler technique, poor compliance to the medication, and presence of comorbidities such as GERD or OSA. So we need to tackle this part before we say that patient having severe asthma. Severe asthma mainly we define as uncontrolled despite maximum, optimized therapy and treatment given to the contributory factors. And then mainly some of our patients dependent still on systemic steroid. Maybe this is from Gina. Severe asthma percentage around 3.7% in asthmatic population. But based on other studies, data as well, severe asthma mainly ranging 5 to 10% of asthmatic population. And then that's why, because quite significant numbers, Gina come up with another guideline, actually, how we're going to treat our difficult to treat asthma and severe asthma. I think they will update the latest recommendation soon in 2022. Okay, when we talk about severe asthma, this is very important too, and we need to identify the phenotype. What type of immune response in this group of patients? Maybe severe asthma we can divide into two groups, either type 2 or non-type 2 asthma. This is based on specific biomarkers, cellularity activation, and then also cytokine release. And then we mainly concentrate on this group because type 2 asthma, mainly they have severe symptoms. And then we have this. We have actually something to offer for our patient, mainly targeted therapy for type 2 inflammation. We have anti-interleukin 5, anti-IgE, and also anti-interleukin 4. Okay, this is recommended by Gina 2019. They are updated into 2019 regarding option of treatment for our type 2 asthma. We need that patient having hypereosinophilic inflammation. So we have several targeted therapy or biologic treatment for our severe asthma patients. And then actually we have the specific criteria how to choose which the best for patients. After we started on targeted therapy, mainly we need to assess again patient, not just simply inject and then you continue for life. This is wrong. You need to assess again your patient in terms of response after 4 months treatment, and then maybe up to 1 year. If our patient not respond to certain targeted therapy, actually we can switch to another one. Okay, this is mainly the drugs that are available in our respiratory unit. Previously, we just only have anti-IgE for allergy asthma, but now this is all the drugs that currently available in our unit. I think that we have about 15 patients on Xolair, and then we have 3 patients already started on benralizumab. This is mainly 2 weekly injection for Xolair. Mainly this is based on serum IgE and also body weight of patient. Fasentra, mainly initially we need to inject every month for 3 doses, and then later every 8 weeks injection. This monthly, and then this is every 2 weeks. And then if let's say our patient not respond to our targeted therapy, type 2 targeted therapy, what we can do, what we can offer for our patients. This is another method that we can offer for our severe asthma patient. This is mainly bronchoscopic approach, what we call as bronchothermoplasty. Mainly this is just apply the thermal energy in our patient airway to reduce the smooth muscle. So this one can prevent bronchoconstriction and then reduce patient symptom. Actually, this is done by our clinic in Serdang. We need to refer to them if our patient indicated for this. Okay, that's the reason, because of increased number of severe asthma patient, and then more options of treatment for severe asthma. So that's why this year we come up with something new that we can offer from our unit, severe asthma clinic. Mainly this is to monitor our severe asthma patient, those already on treatment, and also to accept new referral from everywhere, district, from our ward, medical ward, to be established. And then maybe this patient we can offer something to control their symptoms. And then this is mainly a checklist of referral checklist for severe asthma. This is endorsed by MTS. I think this checklist will be available in MTS website later, soon. Mainly this is very, we also will use this checklist if any one of you want to refer patient to our severe asthma clinic. Okay, mainly this is a few questions here we need to answer, and then the rest mainly biodata of patient, investigation done for patient, and latest medication. In conclusion, I think I'm towards the end of my presentation. After this, my colleague will continue with case presentation. In conclusion, the goals of improving asthma care are to close gaps between current and best medical practice, improve access to care, and then eliminate disparity. So just call us, kan? So now we have 4 of us, Dr. Azhar, Dr. Mat, saya, and then we have one fellow, Dr. Teo. We need to work together to identify gaps and find solution and intervention to close the gaps, especially in our locality, Kelantan State, Kota Baru. A better understanding regarding different phenotypes, variant, may allow for not only greater understanding of the disease, but also direction to improve treatment strategy, especially in severe asthma cases. And then mainly asthma just not only about medication, prescribed inhaler. You need to assess your patient after started on treatment. If patient not responded, need to reassess inhaler technique, compliance, and then assess the comorbids. Because as I mentioned earlier on, certain comorbids can worsen the asthma symptom, especially obesity and also GERD. Before you conclude that your patient not respond to your treatment. If you deal with uncontrolled asthma with limited access and treatment option in your center, please refer to our respiratory clinic, either in Hospital Raja Perempuan Zanab 2 or during our visiting in district hospital. I think with that, I thank you. I invite my colleague Dr. Teo to continue with case discussion.
Sorry, I need assistant for slides. Thank you very much. Very good morning to everyone. My name is Teo from HRPZ, joining this year. So I was given the honor to actually share with you the journey of two patients regarding their treatment in our respiratory clinic. So first case, let's move on to first case. I have a 47-year-old housewife. She was actually diagnosed with asthma after her second childbirth, which was 23 years ago. And with a history of 2 to 3 times of admissions per year, which requiring NAP. And out of all these admissions, actually, you can see that she had a history of 3 episodes of admissions to ICU, and she was ventilated. So from here, actually, I think you can imagine how miserable was her asthma control for this. So prior to that, also she has a history of allergic rhinitis and also gastroesophageal reflux disease occurred. Then we believe that one of her contributing factors of her uncontrolled asthma would be morbid obesity, which charted at 30.9. So this is her spirometry as usual. Whenever we see a patient with asthma, then we do a spirometry on her. Then if you see on top of the spirometry, you can see that it's actually show the reduction of FEV1 or FVC. And both the FEV1 and FVC also reduce. And overall, this is an obstructive ventilatory effect. Yeah. So, and at the same time, so I wish to highlight to you also regarding the post-PD test, which is the post-bronchodilator test here mentioned. It is actually positive for this patient. And in conclusion, this is actually a obstructive ventilatory effect with positive reversibility test for this patient. So this is actually an asthma for this patient. So this is the summary of treatment for the patient. As you can see from April 2014, she's actually on samethero-fluticasone, which is better known to you as Acuvella Seretide 2-puff BD. She's on atopic SR 250 mg BD, Montelukast 10 mg one night, and also salbutamol 2-puff PRN. So in January 2016, if you look carefully, basically it's about the same, except that we changed the dosage of the Acuvella for this patient. So other than that, why we do not change anything for this patient is because prior we conclude the patient has a severe or difficult to treat asthma. We have to identify all the other contributing factors towards her uncontrolled asthma first. So in April 2017, she has a recent admissions to our hospital, and we actually, from the RC, our chest team actually request the patient to be under clinic kesehatan follow-up also, so that we can co-monitor the patient's condition. So she was actually changed to MDI in clinic kesehatan because she felt better with the MDI compared to the Acuvella. So on top of that, also if you can see, she was actually added on tiotropium 5 microgram OD, which is better known to you as a LAMA, better known to you as a Spiriva Respimat. So besides that, also she's on Easyhaler, beclomethasone 400 microgram BD, Tiofilin 250 mg BD, and also Montelukast 10 mg online, which is about the same as previous. Again, we see her back in our respiratory clinic. So on your left side, you can see that this is the format of our respirometry report. Not much of difference if you can remember the figure compared to previous spirometry report that we have. Again, you can see that this is a obstructive ventilatory effect. But at this point of time, we were thinking that this patient, keeping in our mind that there's a possibility of a type 2 or eosinophilic asthma as well. So we did a serum IgE for this patient. So the cutoff point is about 100, it's less than 100 for normal people, but this patient is actually having the number of 765, almost 8-fold raise compared to normal. So back to the timeline here. So in August 2017, she was started on subcutaneous omalizumab, a form of biologics. I believe that you have heard about this. And Dr. Suzila was, I think she has mentioned before that a bit about this agent. So, so since she started on a subcutaneous omalizumab, you can see that actually her medications wise, you can see that there's a difference on her medication. She was actually on MDI, beclomethasone for Montero, which is better known to you as Foster. Then she's on a nasal spray, mometasone furoate, and also for her allergic rhinitis. So the progression, in this case, you can see over the right upper quadrant, of you. This is actually the formal report, the format of our phenol report, which is your fractional exhale nitric oxide report, which usually we see from here. What we can get from this result is we can see whether this patient has asthma. It will guide us whether the patient has asthma, the progression, and also the response when we change the regime of our treatment for this patient. A little bit of a reduction in the phenol reading. You can see that it's a 22 ppb parts per billion to a 19 ppb. It's not that significant, but I do like to emphasize to you that asthma is not only diagnosed through all these modalities, and there are multiple modalities that we can use to diagnose asthma. But comes to the end, asthma is still a clinical diagnosis, I would say. So what we found out from the patient is she has no more admission, and there's no visits to a AD for nebulizer. And what surprised and amazed was actually she has an infrequent usage of reliever as well. So, however, things may not come so easy in our life. So in August 2018, this patient was actually admitted for acute abdomen and laparotomy. She was subsequently hospitalized for almost 1 month. And during her stay in the ward also, she was not given the omalizumab for this patient because there are so many other reasons, or there are so many other factors in which the patient was not given omalizumab. Infections, and after that she has these allergy reactions. So after discharge, patient was not able to come for a monthly injection due to logistic reason. So at this point of time, just run through back regarding the history of her treatment. So from August 2017 to August 2018, she was on her subcutaneous omalizumab. Then from August 2018 to November, she was not even on proper medication. She has defaulted her omalizumab and injection. So as a result, in 2018 November, she was readmitted again for exacerbation of asthma with type 1 respiratory failure. So prior to this admission, she absolutely withdrew all her old medications, the one that I have shown you before that, the multiple inhalers, and she self-purchased her salmeterol fluticasone, which is your serotype, and she used it just like that. So at this point of time, as usual, as we said, we have so many gadgets and we have so many modalities to diagnose asthma. So based on this, also we were just wondering, she has underlying morbid obesity, she has GERD, and she has allergic rhinitis. Would there be any other contributing factors as well, which leading to her uncontrolled asthma? So we did an impulse oscillometry for this patient. So for those who has no idea, or you have heard about this, so this is actually a non-invasive method, which requiring only the patient to stay passively cooperation that allows for the evaluation of a lung function through the measurement of both the airways resistance and also airway reactance. So the impulse actually consisting of a mixture of a sound waves of different frequencies is actually generated by the loudspeaker at your mouth. Then and the wave passes to the lung and causes changes in the pressure as well as the airflow. So this is the concept of IOS working. So it might be a little bit confused, but I think it's good to know actually. It's quite easy to perform. You can just sit there, and then after that you can, if you have a chance, I would recommend you to try it. So a little bit of education here. Just want to run you through so that you can understand better regarding the case. So as you can say, that actually impulse oscillometry actually it measures the airway resistance of airway resistance. So we are using the marker of a hertz for this patient. So R5 hertz actually indicates your total airway resistance, and your R20 hertz is actually your central airway resistance. So for this patient, the R5 hertz or your total airway resistance actually more than 140% is actually markedly increased at 352%. So how we want to define this patient actually has a small airway disease. So we are using your central airway resistance R20 hertz subtract from the R5 hertz. So which is your R5 hertz minus R20 hertz. Your total airway resistance minus your central airway resistance, then you will get your resistance of peripheral airway. Yeah. So as a result, the R5 minus R20 is 236. Or you better look at, if you want a better picture, so you can look at DI5 minus 20. So for normal range, it will be less than 0.07 kilopascal. And for this patient, it's almost 15 times raised compared to the normal. So as in conclusion, actually, this patient has a coexisting of small airway disease, which contributing to her uncontrolled asthma. So as a result, we withdraw her serotype and we started her on Flutiform, NDI Flutiform. So if you're wondering why NDI Flutiform, why not others? Because NDI Flutiform is a form of extra fine particles inhaler that we believe that the small particles actually can travel to your small airway and cause bronchodilation. Yeah. So subacute omalizumab we started and we continue until now. So the word continue until now probably can prompt you also how does the control of the patient. So as a result, she's now well with no visit to ED and taking no more oral corticosteroids. Okay, is that clear? Right. Shall we move on to the second case? All right. Very interesting. This is number one. I would say that the first case is a successful case, rather successful one, and the patient is happy. And definitely the chest physicians are more happy. So case number two, we have a 64-year-old ex-toughness passive smoker, underlying hypertension, gouty arthritis, and also dyslipidemia. She was diagnosed with asthma back in 2002, and with history of intubation, despite she was started on various types of inhaled corticosteroid. So in 2008, she was started on a turbohaler Symbicort. Okay, budesonide formoterol, or better known to you as a Symbicort, as well as a clofazimine slow release of 250 mg BD. Despite no admission and despite her so-called well controlled, because there's no history of admission before, but she still had awakening at night due to persistent productive cough and also limited daily activities. So this is the second time that I would like to re-emphasize again, asthma is actually a clinical diagnosis also. So we have to check on the patient's symptoms as well when they are on treatment. So with the thoughts of persistent productive cough, so on the examination, actually she has some host crepitations, bilateral lungs, then from the chest X-ray also it looks like a bronchiectatic changes. So we decided to send her for a HRCT thorax done in 2015. And which came back, it confirmed our diagnosis of a bronchiectasis as well for this patient. And as day goes by, also she had multiple admissions to the hospital because of worsening of the symptoms. Then after that, treated for the pneumonia with persistent sputum cultures positive with growth of Pseudomonas species and also Maracella species. And besides that, also she has this exacerbation of asthma, which is becoming more and more frequent. So as usual, asthma, then we will do a spirometry for this patient. So as you can see from here, the spirometry, which the FEV1 and FVC over FVC is actually reduced, and this patient is having an obstructive ventilatory effect as well for this patient. However, I wish to highlight on here is actually, sorry, it's a bit run away. The yellow square was supposed to be at the FF25 to 75. We do look at this marker as well sometimes because it will prompt us there's a possibility of a small airway disease in this patient. As you can see, it's about 16% only, which is less than 70% as a cut point for us. So it might prompt us that this patient might have a small airway disease, which causing her to have a frequent exacerbation of asthma. Yeah, so of course we proceed with a full lung function test for this patient. Once again, confirm our diagnosis, obstructive ventilatory effect. And you can see over the right side also there's an increase of the residual volume for this patient, which means that the patient has a hyperinflated lung with a reduction of the DLCO for this patient. So overall, this is actually an obstructive lung, chronic lung. And definitely we will proceed with impulse oscillometry as well for this patient. I just make it bigger for you. If you still remember during the first case that we discussed before that also, but let me just remind you again, R5 Hertz is actually your total airway resistance, R20 is your central airway resistance. So how you get your peripheral airway resistance or your small airway resistance, actually, you subtract the R20 from the R5. So from here, you can see that the R5 Hertz is more than 140%, which is indicate that the patient has a increase of the total airway resistance. Then despite the R20 is normal, it's only 59%, but then if you minus the R5 Hertz minus to R20 Hertz, actually you can get a 0.48 or 109%. So if you look at the DI5 minus 20, 0.4 is about 7 times more than normal range. So which indicates that this patient actually have a small airway disease as well for this patient. Okay. So in January 2018, she was changed to fluticasone formoterol 2-PAP-PD based on the spirometry. So this is another one more thing, or better known as a Foster for you, this MDI. It's another form of extra fine particle inhaler as well. So in February 2019, we have added LAMA, tiotropium 5 microgram OD for her. On top of that also, we have added azithromycin 250 milligram OD for her. However, whenever you see a patient with additional of inhalers, which means that actually the patient has an uncontrolled asthma or uncontrolled condition. And these patients, despite we have added all these inhalers for her, so her symptoms actually never improve. Her MMRC ranges 2 to 3 with asthma control test of 15/25, poor. It's just poor. And what worries most is actually the patient requiring nap at least twice per week at home. So we refer to ENT and gastro team also, and she was started on a nasal spray, and OGTS was done to exclude her whether there's any symptoms of GERD which might worsen her asthma control symptoms. So we did an IgE as well for this patient, which came back. If you remember, the IgE level, normal level was actually less than 100, and this is about 14 times greater. So by considering her IgE level with a localized bronchiectasis and in all this form of inhalers, so she's definitely an uncontrolled asthmatic patient. So that's why we have listed her actually for the introduction of injection of omalizumab for this patient. So in January 2020, multidisciplinary team discussion was actually done based on her case. Then we discussed multiple sites and multiple factors actually we considered also, and we decided that we start her on subcutaneous omalizumab 300 mg 2 weekly, started in February 2020. So as a result, patient is now well, not requiring that at home, and she's not using reliever up until today. Yeah. So she's happy. The quality of life actually has changed. She has becoming, she thinks that her quality has become better. And once again, this is the case of a happy patient and a happier chest physician. So this is COVID pandemic, so we are breathing in a new era now. And this is our chest team. Okay. So with that, I thank you.
Majelis melakukan ucapan terima kasih pada Dr. Suzila Binti Sayuti dan Dr. Tio Ziki di atas penyampaian ceramah sebentar tadi. Majelis dengan ini ingin berikut dan mempersilakan yang berbahagia Dr. Zaini bin Hussein, Pengarah Kesehatan Negeri Kelantan, untuk menyampaikan sisi penghargaan pada penceramah CME pada kali ini. Majelis dipersilakan. Majelis mempersilakan Dr. Suzila binti Sayuti. Seterusnya majelis mempersilakan Dr. Tio Ziki. Majelis merakamkan ucapan terima kasih kepada yang berbahagia Dr. Zaini bin Hussein atas penyampaian CJ sebentar tadi. Hadirin hadirat yang dirahmati Allah sekalian, berakhirlah sudah sesi CME kita pada kali ini. CME pada minggu hadapan akan disampaikan oleh Jabatan Radiologi. Yang itu majlis mempersilakan yang berbahagia Dr. Zaini bin Hussein dan Dikti Liputan untuk ke podium. Kita akan teruskan dengan sambutan Hari Asma Sedunia Klinik Hospital Raja Bronchothermoplasty dan pelajaran klinik asma teruk. Jadi dia diminta kepada semua peserta sambutan Hari Asma Sedunia untuk penuhkan prosedur di hadapan dan terus kita berada di dalam auditorium.